Nephrology unit, Mansour Urology and Nephrology Center. His presentation will be about HCV and dialysis patient. Dr. Ahmed.
Thank you, Mr. Chairman. It's me, Ahmed Yahia, nephrologist specialist at Mansour Urology and Nephrology Center. In 2015, we started treatment of HCV among renal patient project under supervision of Professor Dr. Adel Bakr, and we succeeded to treat 114 kidney transplant recipients, 34 hemodialysis patients, and 16 CKD patients. 4 published articles and 1 article in press in 2019. Today, we will focus on treatment of hepatitis C infection among hemodialysis patients. It was a dream and the dream became a reality. Egypt has the highest prevalence of HCV worldwide. Among Egyptians infected with HCV, more than 90% are genotype 4. The remainder are genotype 1. Chronic kidney disease always impacts negatively on the treatment of chronic hepatitis because of poor drug tolerance. Conventional alpha interferon and pegylated interferon have poor tolerability among hemodialysis population. After the advance of the new direct antiviral agent, the treatment of HCV became more easier and more safe. The problem with first generation direct acting antiviral was the need to be combined with alpha interferon, and the major second generation direct antiviral undergo major renal clearance, so its use in patients with low GFR is doubtful. Reprobation or beta severe ritonavir regimen is mostly metabolized in the liver, so the therapy is not contraindicated for patients with chronic renal failure. Our aim is to answer this question: to what extent reprobation or beta severe ritonavir regimen is effective and safe? Does add-on ribavirin make difference? Is it possible to dispense with the use of ribavirin? Does the removal of dasoprovir from the regimen affect the outcome? Then we will compare our results to those in other studies. This is a single-center prospective study which was held in Mansour Urology and Nephrology Center hemodialysis unit. 96 hemodialysis patients were screened for hepatitis C virus antibody. 46 positive results were obtained. They were then tested for viral load using HCV PCR technique. 38 patients showed positive result. 4 patients were excluded from the study due to advanced cirrhosis or short life expectancy. 34 patients were included in the study. Prior to treatment, clinical examination was done. Jaundice and ascites were not detected in any patient during clinical examination, but 4 patients suffered from chronic lower limb edema. No patient had a history of previous hepatic encephalopathy. Laboratory investigations were performed in the form of ALT, AST, bilirubin, albumin, cholesterol, complete blood count, INR, alpha-fetoprotein, and HCV genotyping. Radiological assessment to determine the degree of fibrosis. All 34 patients received 12 weeks of direct antiviral that included 24 mg, 25 mg of beta severe, 150 mg reprobation, 100 mg ritonavir, administered orally once daily. Ribavirin 200 mg per day was added for 10 patients that had baseline of more than 10 g per deciliter and white blood count over 2,000 per millimeter cubic and platelet count over 100,000 per millimeter cubic. The follow-up period after treatment completion was 6 months. Our patient age was around 43 years. Most of them were males with body mass index 23.8. 2 patients had previously treated with alpha interferon, and 2 patients had been co-infected with hepatitis B virus. Most of our patients were child A and with fibroscan F0 to F1. All our patients were genotype 4. The treatment proved its efficacy as all patients were cleared from from the virus within 4 weeks after starting treatment, achieving 100% rapid virological response. 33 out of 34 patients achieved 12-week and 24-week sustained viral response with significant improvement in transaminase levels. Here we studied the effect of adult ribavirin. Regarding the efficacy, there was no statistically significant difference. Nearly all patients achieved rapid virological response and there was only one relapse. But anemia was more relevant among the ribavirin group. And accordingly, SATU's 4 weeks from starting with treatment was higher significantly among the ribavirin group. In spite of decreasing ribavirin dose to 200 mg every other day and using IV iron therapy, 5 patients needed to stop ribavirin and anemia didn't improve. Regarding the relapser, this patient was aged 67 years. He had been previously treated with alpha interferon. Before starting direct acting therapy, liver fibroscan was F2 and the child score was P. HCV PCR was negative 1 month after treatment. 2 months later, he developed ascites, jaundice, and lower limb edema. Transaminases rose up. HCV PCR became 4,000 and alpha fetoprotein was normal. He was managed by daily hemodialysis, IV albumin, and orthodoxycholic acid. The patient improved clinically and laboratory investigations became normal within 3 weeks. Unfortunately, he developed HCC and died 18 months later. This combination is known by its drug-drug interaction. So, 18 patients were receiving amlodipine prior to treatment were advised to stop it before starting treatment. 1 patient received carbamazepine, 200 mg per day, for peripheral neuropathy. He continued taking this medication without informing us. Fortunately, he didn't experience a virologic failure or relapse, and we didn't follow up the concentration of carbamazepine. On comparing our results to 6 previous studies, we have relatively large number of population, especially with genotype 4, and also we have the advantage to divide our patient into 2 groups, ribavirin versus no ribavirin group. Also, we didn't use the saprophyrin in our regimen. We have high rate of rapid virological response and sustained viral response. The most common complication was anemia, and really it was relevant in our study, 10 patients out of 34. On comparing to Group B1, in Group B1 study they also used ribavirin, and anemia was significant there also. In Group B2 they didn't use ribavirin. ONX was exaggerated during treatment, during HCV treatment. In conclusion, in real life, the beta-prevail and beta-severe ritonavir regimen, with or without ribavirin therapy, was safe and effectively treated Egyptian HCV positive genotype 4 hemodialysis patients. At least in our patients, addition of decibelvir didn't seem necessary. Avoiding ribavirin was associated with fewer adverse events and better tolerability without affecting the efficacy of the therapeutic regimen. At last, I would like to acknowledge HCV working group in Urology and Nephrology Center and Egyptian Liver Research Institute and the hospital team. Thank you.
شكرا جزيلا دكتور احمد for nice and concise presentation. انا كنت عايز اسالك اخر ابديت عن الريفلنس والتايت سي وورلد وايد، مصر بقى رقم 1 ولا مصر بعيده عنها؟
I don't revise, but I think it will not be that large population yet.
بالظبط.
Yes.
هي مصر ما عادتش رقم 1.
ما عنديش داتا بالظبط.
عندك داتا دلوقتي؟
نعم.
عندك داتا على النقطه دي؟
هو مصر كانت expected انها تبقى 15 to 25%، طبعا 25% excluded، لكن هو دلوقتي بيتكلموا actual number 6 to 7% من البوبيليشن.
ومين الليدر؟ مين التوب كانتري؟
في كاميرون والجابون دول اعلى مننا، سب سهران افريكا، بس هم برضه ما عندهمش احصاء دقيقه يعني. السؤال الثاني انت اتكلمت عن حته مهمه جدا، السايد افكت اوف ذا دراج. يعني البريفلنس تقريبا كام برسنت، وايه اخطر سايد افكت شفتوها غير المورتاليتي
هو اكتر حاجه شفناها بالنسبه للهيموداياليس بيشنت كانت الانيميا with ريبافايرال. without ريبافايرال الانيميا was not significant. طب تاني سايد افكت اتكلمت عليه اللي هو الاكزاجيريشن اوف بودي ايج. دي كانت حاجه موجوده في
حد جاله كرايم؟
نعم.
ولا we didn't examine؟
لا لا
شكرا جزيلا. شكرا. سؤال؟ طبعا اتفضل دكتور محمد بيه.
انا بشكرك جدا بصراحه. جود ورك لما كل حاجه. يا ريت البروتوكول اللي حضرتك عطيته بتاع الفولو اب عشان الانيميا، لان انا لاحظت كنت بتعمل كل شهر كل فتره وصور كيسز والانيميا انت ريفيرتش فيري ايرلي. احنا ساعات بنشوف حالات حضرتك بتيجي بعد ما ياخد الموبايل جرعات اعلى من كده ويجي يديله 7. فيعني يا ريت البروتوكول ده دكتور مجدي حضرتك نقدر نعمل له ابلكيشن في كل الوحدات بتاع الفولو اب بتاع البيشنت وبتاع الدراج انتراكشن، لانه فعلا في منتهى الاهميه. ده بياخد مننا مجهود بقى بلاد ترانسفيوجن وقيسه تاني وايرون ثيرابي، وده بيبقى نتيجه ان البروتوكول من الاول خالص المحطوط مش متظبط جرعه ريبوفاير.
حتى حضرتك مع جرعه الريبوفاير اللي هي 200 مللي جرام الادفايز مع يمين الهيمودايليسيس بيحصل انيميا. لا ما في، لازم عشان كده دلوقتي بقى في ريبافايرين فري ريشن. اوكي؟
ثانك يو.
دكتور احمد. نيكست سبيكر.
طبعا نظرا للتشينج في الجدول، بس انا هقدم الاستاذ الدكتور احمد دنيا، صديق عزيز ويعني اخ من الاخوات اللي بنعتز بيهم في مصر وفي المنصوره. احمد بايونير في النفرولوجي ومن اعمده المنصوره في مركز الكلى، وبيشرفنا يعني مش كتير بس بنتشرف بيه دايما في الانيوال دايليسيس كونفرنس. احمد دنيا ان شاء الله النهارده هيكلمنا على very interesting subject related للهيمودياليسيس volume status in CKD and hemodialysis patients, which is very interesting subject. احمد اتفضل.
شكرا جزيلا استاذ دكتور مجدي الشرقاوي على تشريف الدعوه الكريمه. Today I will talk about volume status in chronic kidney disease and hemodialysis patients. Total body water constitutes 60% of our body, and 2/3 are intracellular and 1/3 is extracellular. And we are in a continuous state of balance relative to sodium and water. Despite both of them work in an integrated fashion, yet both have different mechanism. And I know that this might be a little bit confusing for young nephrologists, but disorders of sodium balance will not change serum sodium, but will lead to volume changes. And on the contrary, disorders of water balance will not lead to volume changes, but will change sodium concentration primarily. Starting with water balance, we might have disturbance in the form of loss of free water, and this will lead to hypernatremia. And we might have disturbance in the form of retention of much free water, and this will lead to hyponatremia. And both hypo and hypernatremia will change serum osmolarity, which will play with osmoreceptors, changing the adaptive mechanism, mainly thirst and antidiuretic hormone. So, for example, in hypernatremia, thirst mechanism will be stimulated, encouraging us to drink more free water and replace lost fluid. On the contrary, sodium changes will lead to volume changes. So, if we retain much sodium, This will lead to extracellular fluid expansion, hypervolemia, raised GVP, high blood pressure, edema, and so on. And if we lose much sodium, this will lead to hypovolemia. And the adaptive mechanism in this situation is playing through urine sodium excretion. So both opposing RAS and the natriuretic peptide will work to adjust urinary sodium, which will adjust changes in volume. Of course, kidney is central to both water and sodium mechanism. And in kidney disease, there might be changes in water metabolism so that we might have hyponatremia in chronic kidney disease. But chronic kidney disease much more affects sodium metabolism. So we have more sodium retention and more changes in volume rather than level of sodium in the form of hyper and hypovolemia. And this is my talk today. Volume changes have drastic consequences. Hypovolemia will lead to hypotension, increased morbidity and mortality, and rapid loss of kidney function. At the same time, hypervolemia will lead to hypertension, again increase in mortality as evidenced by this study, which included 40,000 end-stage renal disease patients, clearly showing that hypervolemia will lead to more mortality, whatever blood pressure is. And like hypovolemia, hypervolemia will also lead to rapid CKD progression. Look at this trial, which included 500 CKD patients, and clearly showing that the more the fluid retention is, the more the rapid deterioration of kidney function. Volume changes are prevalent among CKD patients, especially volume overload. This trial included more than 300 patients with CKD, and here is zero or eovolemia, and this is the narrow range of volume status in the general population. And in CKD patients, more than half of them are hypervolemic, 5% of them are hypovolemic, and only less than 50% of them are avolemic. Assessment of volume status in CKD patients is challenging. No single tool alone could be helpful. Clinical assessment starts with meticulous history taking, which could be very helpful despite often overlooked. So simple symptoms might denote volume status, taking in consideration that sometimes symptoms are overlapping. Assessment of body weight is very important, however it is affected by nutritional status. Measurement of blood pressure is very important, taking in consideration that normal blood pressure might be the case in hypervolemic patients and vice versa. Edema might be helpful, however it is absent in large proportion of overloaded patients. Also, crackles might or might not be helpful. Assessment of GVP is helpful, but I have to admit that this assessment is difficult, and it's also prone to negative and positive false assessment. For example, superior vena cava obstruction. Despite all these pitfalls, this study concluded that clinical judgment is still the single most important factor in assessment of volume status among CKD patients. So clinical evaluation is very important, but should be taken in the context of that many patients with volume overload do not show signs and symptoms of volume overload and vice versa. The ideal method of volume status assessment is what's called dilution method. For example, radioactive potassium to accurately assess intracellular compartment. However, these reference methods are invasive and very difficult to apply in clinical practice. Measurement of CVP or placement of pulmonary artery catheter might be helpful in some critically ill patients. However, again, invasive procedures not suitable for chronic patients. Chest X-ray might be simple, helpful tool. Heart rate variability is an attractive, simple, non-invasive tool, just measuring the time interval between each heartbeat. And if there is variability among beats, this is good, because loss of variability means sympathetic overactivity, which denotes more stress, more probability of increased morbidity and mortality, and more importantly, linked to fluid overload among hemodialysis patients. Heart rate variability could be simply measured by wearing heart rate strap like a watch and connecting it to a smartphone software application. Carotid artery Doppler might be helpful, but needs more standardization. Inferior vena cava measurement is rapid, non-invasive bedside assessment for volume status. It depends on IVC diameter measurement and assessment of IVC normal collapse with inspiration. In volume overload, IVC diameter increases and collapsibility decreases. Again, some pitfalls with IVC measurement might be dilated in normal subjects, lack of standard reference about diameter and collapsibility. Lung ultrasound is another attractive, non-invasive tool which expands point-of-care ultrasonography for nephrologists. If you find these transverse hyperechoic lines, this is normal. But if we find these longitudinal hyperechoic lines, what's called lung comets, this is abnormal. This denotes pulmonary congestion. Again, despite easy and simple, it cannot differentiate between fibrotic lines and edematous lines, for example. Bioimpedance is very common in private clinics in Egypt for diet. So the doctor will tell you, just give me 1,000 pounds and they will draw everything for you. Your water, your fat, your bone, everything. And this is bioimpedance. It depends on the passage of electric current within the body. And according to changes in this electric current, bioimpedance will be measured automatically. Bioimpedance might involve the whole body or might concentrate on a segment in the body. Again, it might use simple technology, what's called single frequency current, which only measures total body water, or it might be more complicated, what's called spectroscopy, with detailed fluid assessment. To my mind, the only validated machine for bioevidence for clinical use is that of Fresenius and could be used in CKD and hemodialysis patients with some evidence of usefulness for estimation of volume overload among hemodialysis patients. Again, it needs a standardization for technique and the protocol of bioimpedance. I think yesterday we enjoyed the talk of Professor Cano about biomarkers in hypervolemia, and we learned about BMB and the ProMB in hypervolemia and heart failure, and co-peptin in hypovolemia. Nevertheless, we know that biomarkers are not very accurate in CKD, making KDIGO to recommend to interpret their results with caution in CKD patients. So perhaps combined approach might be more feasible, like this study which combined bioimpedance with biomarkers. And it showed that this combination had the highest prediction of mortality. Blood volume monitoring is also non-invasive, helpful tool. For example, we measure blood volume at the start of dialysis and at the middle of dialysis, and we calculate what's called relative blood volume, or RBV. This could be done via a machine which is linked to hemodialysis machine, and it is manual adjustment. So the nurse can observe that blood volume is coming down, so she manually adjusts hemodialysis machine, or could be more smart, more integrated and automatic within the machine, what's called the biofeedback system. So the machine automatically senses blood volume and automatically changes ultrafiltration and the sodium profile. For example, Gambro ARTS machine with hemo control option. Sodium MRI. So we'll go through this. So coming to management. Remember that we are talking about hypo and hypervolemia, so sodium is crucial here. I think the principle and the core management of volume states changes in CKD among a plethora of medicines is counseling. It's very important to counsel the patients. If we are talking about non-dialysis patients, sodium restriction is central to treatment. So sodium restriction will not only decrease volume overload and blood pressure, but will also decrease proteinuria in CKD patients. KDIGO recommends to decrease sodium chloride intake below 5 grams in CKD patients. Interestingly, KDIGO does not mention a statement about water intake. Sometimes we are obliged to use diuretics in non-dialysis CKD patients in order to control for volume overload. And this is a real dilemma, because we know that both hypovolemia and hypervolemia are associated with CKD progression. So we are in a state of difficult balance. That's why this article called it a complicated triangle to use a diuretic in CKD patients. And comparing 150 patients who used diuretics to another 150 patients who didn't use diuretics, diuretic group showed more rapid kidney function deterioration and rapid start of renal replacement therapy. Whether this is due to diuretic itself or due to the overall condition of the patient is unknown. Therefore, we frequently obliged to use diuretic therapy in CKD non-dialysis patients to control volume, and we sometimes use diuretics in dialysis patients to facilitate treatment. Loop diuretic is the principal diuretic to use. Nevertheless, thiazide diuretic might also work. Potassium-sparing diuretics should be used, if any, with great caution. And there is one point here. In kidney disease patients, there is something wrong about time course of urine drug delivery of loop diuretics, making them more susceptible to complications. And there is also another concern about diuretic use, is the state of hypo or hypervolemia. Both of them, as I have just mentioned, will deteriorate kidney function. When to start dialysis and dialysis in non-dialysis CKD patient, I think it is a rational statement from the KDOQI guidelines that initiation of dialysis does not depend on a specific level of kidney function. Rather, it depends on when you are unsafe to treat your patient regarding volume overload and other metabolic abnormalities. Coming to dialysis patients, KDOQI guidelines give us holistic general view so that reduce dietary sodium in dialysis patient intake, adequate salt and water removal, and prescribe ultrafiltration rate to achieve euvolemia, just general roadmap. We have to adjust dry weight of the patient, and sometimes we need to change dialysis session. For example, to extend dialysis session in order to treat hypervolemia or to treat hypervolemia in hypotensive patients. We might also use short daily dialysis or nocturnal hemodialysis, which is frequent nocturnal dialysis. Despite that, it was mentioned in KDOQI guidelines, unfortunately, even this slow nocturnal dialysis might be associated with more rapid deterioration of kidney function. What about salt and ultrafiltration profiling? No clear statement for that, and we are in need for randomized controlled trials. And perhaps the institution and the use of intelligent machines which automatically interpret many factors might be very helpful. And last word about residual kidney function. Even in patients on dialysis, we have to conserve residual kidney function for better management. Thank you very much.
شكرا جزيلا بروفيسور احمد دنيا for elegant updated lecture. دكتور علاء عايز طب يعني one
Just one simple question. As usual, Dr. Ahmed, excellent presentation. أنا عندي comment بس على two compartment models for the classification of intra and extra vascular volume. I think there is an updated one which is a third three compartment model which considers sodium. انت mentioned that in very rapid. انا عارف انت فوتت الMRI للصوديوم. وفي كومنتس كتير قوي عن موضوع الصوديوم سيكوستريشن في الاسكان وفي البون وعلاقته بالانسولين ريزيستنت وعلاقته بالاميونيتي.
Yeah, I fully agree with you, and I think sodium MRI is an emerging technique, and even there is something like bedside complementary magnetic assessment of the patient. So sodium is very crucial because the whole story starts with the sodium. I fully agree with you.
شكرا جزيلا دكتور احمد. فيري نايس برزنتيشن. هسألك بقى حاجتين، هقول لك على حاجتين. اولا انت قلت ان most of CKD patients are volume overloaded. I totally agree. يعني البيشنت اصلا CKD even if it is not edematous مفيش evidence لكن هي عنده water. ودي نقطة مهمة جدا. النقطة الثانية الدايوريتكس. When diuretics are injurious to the kidney. يعني لو patient جالنا CKD 2 or 3 heart failure, edematous, pulmonary congestion, would you treat him with diuretic ولا حسب ما انت قلت it will deteriorate his kidney function?
I will treat bravely with diuretic. So I think we have not to prevent use of diuretic for fear of hypotension or volume contraction. Rather, we have to strictly follow up the patient. But I think diuretic is crucial and very important part of treatment in hypertension in most stages of CKD.
All type of diuretics. Which type is?
I think loop diuretic is
the best.
the first and the best. Yeah.
دكتور حسين ثم الدكتور عمرو.
طبعا لازم نحيي الدكتور احمد، فيري سمارت برزنتيشن، قعدته وفارس ضربت في التدريس وتهذيب المعلومات. بس عاوز مش سؤال يعني اللي هو على الكومنت بتاع الدايوريتكس، عشان الدكتور مجدي سال السؤال بتاع الدايوريتكس. واحد من البيتفولز مانجمنت اوف داياليسيس بيشنت ان انا اسلوب الدايوريتكس للعيان، فسو لونج از بجيب بول المفروض الدايوريتكس تبقى موجوده. بالعكس ده بنزود الجرعه علشان تمنتين يورين اوتبوت، لان ده بيسهل لنا المانجمنت بتاع البيشنتس. فالمفروض الدايوريتكس ديت ما يعني نديها وضعها اكتر من كده في الرينال فيلر والداياليسيس بيشنت. شكرا جزيلا.
Thank you, Dr. Donia, for your excellent presentation. You usually ask me questions after my talks, so I have to ask you some questions, I think.
But it was humble, simple questions.
The same here. So just two quick comments. We usually use very popular in the USA the CRET line, continuous measurement of hematocrit, so give you an impression about the hemoconcentration. Other thing we sometimes use, which is a little bit complicated and rare, but in patients with frequent pulmonary hypertension, frequent pulmonary edema, and severe pulmonary hypertension, NIHA class 3 and 4, we use sometimes something called CardioMEMS. It is a microchip. The cardiologist can put it in the pulmonary artery by right side of the heart cath without using the contrast, and it continuously measures the volume status of the patient. It's like a swan, cap all the time. Give the patient have a, sleep with a pillow, and this pillow have a sensor. So this microchip transmits the signal to the pillow, and there is a 24-hour measurement, and somebody has watching
Cordless,
this.
like cordless
That's cordless.
pacemaker.
Exactly. It's remotely monitored, so we can have an idea about what's going on in the volume status of the patient 24 hours. Other question for you, very quick. I'm sorry?
No, the CRET line.
الكريت لاين ده dialysis. لكن في البيشنت اللي هم عندهم severe congestive failure class 3 class 4 you can cardiologist ممكن تساعد في بالذات الناس عندها cardiovascular syndrome frequent pulmonary edema.
الكريت لاين is not sensitive.
صحيح it's all tools. That's right. There's no standard of care or excellent parameters that give you the whole thing. Just one more question for you. Can you please comment on cooling down the dialysis temperature to avoid intradiabetic hypertension?
Yeah, I think this is one of the successful modalities to decrease intradialytic hypertension. And it is traditional in my center to use cool dialysate for all patients. And I don't know if this is right or wrong, but we did it for all patients. 36.
شكرا جزيلا بروفيسور احمد دنيا. we'll shift to the next speaker. دكتور عمرو شاكر. دكتور عمرو شاكر will speak about